Hello, thank you for coming. It's my distinct privilege and pleasure to introduce Dr. Clark, our speaker today. Dr. Clark, I'm known for quite a few years, and I think we're really going to be in for a really timely but also very important talk. So I'm glad we have a really good attendance today. I'm going to read a little bit about it, but I'm also going to say a few words about Dr. Clark. Dr. Clark's both certified in both addiction medicine and psychiatry, and as a practicing physician, clinician, and business leader, and recognized national expert on issues related to substance use disorders involving opioids as well as other illicit prescription substances. She is the immediate past president of ASAM, the national president of the national organization ASAM. And she's not somebody you would necessarily know about all of her achievements or accomplishments from meeting with her. She's extremely humble, but a highly skilled communicator and a professional leader in the field of addiction medicine. She's led the national organization of ASAM at a critical time in our history of addiction treatment in our country with the current crisis, particularly the crisis involving the intersection of COVID and the opioid epidemic. I first met Dr. Clark when she was helping to establish or reestablish the Kentucky chapter of ASAM and was the president of the KYSAM chapter after it had been inactive for a period of time. And she's been extremely influential in the state of Kentucky as well as the country in addiction medicine. We're really fortunate to have someone of her caliber here and in our area too. She's also a local resource for us. She was one of the first people who helped who was talking or really in a way that the insurance companies could understand about why it's important to cover addiction treatment services like evidence-based treatment, like buprenorphine or medications for opioid use disorder. And she's been a fierce advocate for that. She's worked in the sector of as a CMO and as a medical director for CVS Caremark and also for other large behavioral organizations. She has worked in the field of education. She was a clinician and worked at the University of Massachusetts, where she taught medical students and residents about addiction medicine. She is extremely, again, a professional leader, meaning that she brings together people and is really excels at bringing groups together. And for a cause, particularly in this case, for addiction treatment and for access for addiction treatment for the United States, for our population. She has been somebody that I have found very helpful, particularly in the COVID epidemic. When we were first facing this, we were facing a real crisis about what do we do with our patients who are receiving medications for opioid use disorders. And she was somebody who was very helpful to me personally on how do we navigate this and how do we continue to provide access to care to our patients in the midst of this crisis. She has been an outspoken leader in not just as ASAM, but she's been testified actually in front of Congress many times. She's someone who is sought out by the highest levels of our government and the people who put together policies, and as far as it has helped also put together and influence a lot of the funding initiatives that we have benefited directly here at university from. She's an extremely important person. And again, I'm really thrilled that she's here today. I hope we can use her and utilize her as a resource in our department going forward. And again, I thank her for coming, and I thank Dr. Faruqi for having the forethought to have her here today. So with nothing more, I'll give you Dr. Clark. Looking forward to hearing your talk today. Thank you.
Wow. Well, Dr. Stewart, that's really tough. I'm not even sure what I say after all of that. Boy, I guess the thing that I need to do right now is figure out how to share my screen. I think somebody needs to give me the option to share my screen. No, there we go. Sharing. And you get my incredibly busy screen. Okay. So is that too small to be seen?
There you go. Go into presentation mode.
I'll go like this.
Okay.
Okay. All right. Well, with that said, thank you very much. I appreciate the opportunity to be here and address you. I was hoping to do so in person, but here we go. So as I was saying, I think I get, 2 hours here at the special seminar to tell you everything I know about addiction. Wait, it's an hour grand round. So I'm going to go really fast. So buckle up. Here are my disclosures. They're not relevant to the discussion, but I like to be very, so that you can see everything that's going on with me and very transparent. This is the form that I need to show you. These slides are going to go through a couple things. We're going to talk about, sort of as a psychiatrist, addiction as a chronic brain disease and what that means for treatment. And then I'm going to go through a systems approach as we think about addiction as a chronic brain disease. And here I'm going to rely on this paper that we did as part of the National Academy of Medicine's opioid collaborative in the prevention, treatment, and recovery work group. So that's what I'm going to be referring to in the back part of this talk. And don't be afraid, the slide, there are 1,000 slides here, and they are really for your reference, not for my reading of you. But that being said, for all you Shakespeare fans, they are words, words, words. So they're not very engaging visuals. These are your references. So starting at the very beginning, psychiatrists, your patients have substance use disorders. Your physician colleagues and the general public think that you treat substance use disorders. These are DSM-5 disorders. So I would ask you, do you not treat substance use disorders? Of course you do. So let's start with definitions of terms, because there are really no generally accepted terms. So we're going to have some for our discussion today. So I'm going to say use. Use is taking a substance for a desired purpose. Example, I had coffee this morning. Substance use. Misuse, taking a medication for a purpose other than as prescribed. So technically that's if you're supposed to take something twice a day and you take it, at bedtime, 2 doses, that's misuse. We don't talk about abuse because it's a stigmatizing word. And also elder abuse, child abuse, drug misuse is not something that's harming the substance. So abuse is really a term that we don't use. Diversion, you hear a lot about diversion in the substance use disorder arena. And basically, that's just when a medication leaves the approved distribution channel. So it's supposed to go from manufacturer through distributor, through retail pharmacy, through to the patient who takes it exactly as prescribed. And you'll hear a lot about, there's diversion of Suboxone. There's about as much as you would expect for how often it's prescribed as a controlled substance. And there is also a large amount of diversion, using the actual definition, of non-controlled substances like antibiotics and blood pressure medicines. So just something to keep in mind. We often get confused and conflated about things, thinking, risky doses, that does not imply a disorder or an addiction, right? So an unhealthy or risky use for alcohol for a woman is more than 1 drink a day, more than 7 drinks a week. And for a man, it's more than 2 drinks a day, more than 14 standard drinks a week. Above that, it's a risky dose. It has health implications, right? About one in every 20 cancers in this country are attributable to alcohol intake, mostly gastrointestinal cancers, but also women's and men's risk of breast cancer goes up straight line with every alcoholic beverage consumed. So drinking more than this does not imply a disorder. So physical dependence, not addiction, not a substance use disorder, right? Dependence, always a board's question. Dependence is that physiological state where the organism has changed itself to a different sort of homeostasis, where there is tolerance and a person needs to take more and more to get the same impact, or there's a withdrawal syndrome that happens when the substance is not supplied or is drastically decreased, right? A substance use disorder is defined by the APA in DSM-5. Before DSM-5, we did have substance dependence, but it got very confused between what really we mean by an addictive disease, a primary addictive disease, and physiological dependence. So DSM-5 changed that. And when I say drug addiction, I'm defining this by ASAM, which is it's about 6,500 docs and some allied health professionals specializing in addiction medicine. But basically, my shorthand for the population is addiction is a chronic disease. We can't see it from blood tests. We're not going to do really functional imaging to diagnose this. We see it because a person has lost control of their drug use, and then they lose control of their lives because of their drug use. Two more definitions: remission and recovery. So remission, any disease, right? A return to a level of functioning without active signs and symptoms of the disease, right? Or there's some level of stability in there, right? And recovery is a different thing. Recovery is an active process where a person really actively manages their chronic condition and is living their best life by addressing all of the things about a chronic condition that can impact their living their best life. Remission is a medical goal. Recovery is a whole person goal. And here's my first best tip for you. Whenever you're considering how to approach the disease of addiction, or you're talking about substance use disorders, and you mean a point where there's moderate severe disorder, substitute the word diabetes or schizophrenia or epilepsy into whatever you are thinking. And if it doesn't make sense, reconsider your approach. Reconsider your approach if you can't substitute the word schizophrenia for addiction. So people with the disease of addiction should be treated the same as those with other diseases. Okay, so what I'm giving you here is some kind of backgrounds around the way we approach treating other conditions by healthcare. So keep that in mind. Chronic brain disease. Chronic brain disease. This is actually from George Koop and Nora Volkow's work that got subsumed because they work for the government into the Surgeon General's report of 2016, which is a superb report. There are going to be some slides at the end with resources for you, but you should look at the Surgeon General's report on addiction in 2016. And this goes around some of the brain areas and some of the kind of constructs of we sort of go around from this binge intoxication into a withdrawal, into preoccupation and anticipation, and round from basal ganglia through extended amygdala and then through the prefrontal cortex. And one of the things that happens here that you can imagine with dependence also is less of an issue that people want to use a substance in order to feel great than, if they're dependent, to stop their withdrawal syndrome. Right? So there are both sort of rewards as well as sort of a negative reinforcement that's in place in the cycle of addiction. And this is this really classic study of Nora Volkow's. And this was with cocaine use. So these are people who didn't use cocaine, then some chronic users a month after their cocaine use and 4 months later. And what we see here is really this construct lit up for us in functional imaging, that the brain is altered in addictive disease. And what we haven't seen is it change back to baseline. Okay, we've seen it trend back to baseline, but we haven't seen it go back to baseline. And in fact, if you look at people's brains who are on autopsy, after autopsy and brain bank, if you look at people's brains who've been heroin addicted or alcohol addicted, what you see are actual epigenetic changes sort of diffusely throughout the alcohol addicted people's brains, as opposed to specific epigenetic changes in specific brain regions for people who've been heroin addicted. So party line is that addiction is a disease, but the truth is that as these play out, they're really different in the brain. So using a construct that addiction is a chronic brain disease, well, what does this mean? Okay, so a disease, this means we know how to manage diseases, right? We use a biopsychosocial approach. We use a medical approach where a physician is involved, doing assessments and treatment plans and et cetera, right? Brain means stigma. Brain has always meant stigma. You know this as psychiatrists. You know, many parts of the world, they still consider people with epilepsy to be demonically possessed. You know, we've come a long way with neurological diseases and psychiatric diseases. And basically, right, the difference is that neurological disease is a psychiatric disease that we now know the etiology of, right? So they take it away from us and it becomes a neurological disease. We haven't come anywhere near that with treating the disease of addiction. And chronic means that we have to help a person manage their disease state. Okay, so use this example of diabetes. Okay, so imagine a person who's got diabetes who is not really controlling their disease state. Right? So they're in and out of the emergency room in DKA. They may be in such bad shape, they're admitted. We normalize their sugar, we give them treatment. Now, what do we do at that point? Do we discharge them without any insulin, send them home, and then when they come back, say, well, why? We showed you what to do. We taught you about your diet and exercise. Why are you back here in DKA? Then we send them to a 28 days where they're going to get maybe medicine, but very tightly controlled diet and exercise. And then we discharge them and then we blame them when we come back. This makes no sense, right? So say the person is actually now monitoring and actively managing their disease state, okay? And they are checking their sugars and they're doing their diet and exercise pretty much, okay? And then they go to a party and they have a piece of cake and a beer. They are not adherent to their treatment plan. Do we say this is a failure of their treatment plan and they need to have a change? No, of course we don't do that. We don't expect people to be fully adherent to any treatment plan for any disease. Why would we expect this of addiction? Simply stigma and discrimination, right? We can't just say, here's your insulin, there you go, and now I've treated diabetes, right? They're never going to get control of their sugar until they go through the psychological and spiritual issues that may be apparent. Those of you who've had to tell a teenager that they've got type 1 diabetes, they have some spiritual crisis going on with that as well. But do we do this with, we can't just say, you know, here's your buprenorphine, off you go. If the person with diabetes family is having, you know, a bowl of ice cream every night, they're not going to get their sugar controlled. This becomes a family issue as well, right? For training and support and etc. So we don't measure the outcomes of a treatment plan in terms of a chronic disease by, say, diabetes from time to first cupcake. That's ridiculous. And we shouldn't be saying for addiction, the time to first drug use. That's ridiculous, right? So what are our goals of treating a chronic disease? What are our outcome goals? They're not cure. It's not an acute infection. It's not an acute break. Think schizophrenia. Well, our desired outcomes are decreased disease-related early morbidity, decrease disease-related early mortality, decrease the disease-related total cost of care as they cycle in and out of the inpatient units, and also to improve their quality of life and improve their functionality, right? Those are the goals of managing a chronic disease. So what do we know about the risk to develop addiction? Not unlike other psychiatric diseases, large genetic loading, trauma history, and multiple comorbidities are there. The other thing that we know here is that early drug use of any type, and people use what is available to them, is an increased risk factor, and increased brain exposure to drug increases risks. So is cannabis a gateway drug? Absolutely. Alcohol is a gateway drug. Any drug that is going to be a drug that can cause addiction is going to be a gateway drug if that's what people start using. Now, in all medical care, we're driving toward better and more standardized kinds of approaches with more integration and coordination and quality metrics and et cetera. And this is true, you know, for all diseases. So how do we treat a chronic disease? Individualized treatment plan based on structured best practices, biopsychosocial and spiritual approaches as appropriate. And this means right provider, right modality, right place, right doses for as long as needed at a specific point in time for that person. Right? We don't say, okay, gosh, you're coming in with chest pain. You're going to get 3 days in the hospital. Now you're going to go to a sniff for 2 weeks. Now you're going to go for cardiac rehab for 1 month, and then you're going to go see a cardiologist. No, That's not how we would do this. And we wouldn't say, well, you first come in. So first I'm going to start you with a cardiologist at the very lowest care. And then I'm going to step you up if you fail that. No, we have to match the person coming in with their chest pain to what it is they need at that point in time. Now, our addiction treatment system doesn't really exist. Historically, it was built outside of the medical system and outside of the psychiatric system, as you well know, generally grant funded or self-pay. The training levels of staff in the addiction treatment area are far below what you see in what you would call the quote mental health area. In behavioral health, we typically think of mental health, substance use disorders, and then health behaviors. In mental health systems, typically the staff, the people providing care can bill independently. They're master's level and above. What we have in the U.S. addiction treatment system is not that. We have people who are providing care that have maybe high school diplomas, maybe have an associate's degree. The level of care for licensure in the U.S. is all state dependent. And so there's wide variation in what these levels of, what both the level of care and the clinicians have to be to provide each level of care. And there has been an over-reliance on inpatient care, particularly for detox, which we call medically supervised or medically monitored withdrawal. Really, the people who might need medical supervision or monitoring of their withdrawal, I call them the 3 Bs, benzos, barbs, and booze, because those are the drugs where if you stop them, people can die. Very rare you're going to have somebody who's going to die from an opioid withdrawal, maybe if they're on dialysis, they've got esophageal varices and they're throwing up, right? It's very rare that you're going to have a severe medical complication from an opioid withdrawal. Very little medical complications from cannabis withdrawal or stimulant withdrawal, right? There is no reason for most people with a physical dependence on anything other than benzos, bars, and booze to almost ever go to a detox to get those drugs out of their system in a safe way. And if you don't know, the construct of a 28-day program is what the state of Minnesota would pay for. This is not evidence-based care. This is not care that's supported by ASAM. 28-day treatment as a program, not actual treatment. And while I'm talking about benzos, bars, and booze, let me talk about these 2 alcohol treatment guidelines. And they go together. They're complementary and synergistic. The first on the left is the ASAM clinical practice guideline on alcohol withdrawal management. People still die in hospitals from the DTs. They still die. It's astonishing to me. You're a psychiatrist, you should be able to manage alcohol withdrawal in a hospital setting when you're being consulted by your physician colleagues to do so. And the guidelines are there. When you're not dealing with an acute situation, when you're talking about ongoing pharmacological treatment of people with alcohol use disorder, then you've got the APA's guideline to the right for the ongoing management of those patients. Okay, so right provider, what right providers, addiction physicians, you know the levels of clinicians down here. Where are the psychiatrists in my slide? Well, they kind of go under addiction physicians, but they don't usually go as psychiatrists because for reasons that are historical and perhaps not, psychiatrists and mental health system generally abdicates responsibility for treating substance use disorders. So those are providers. When you get to levels of care, what's the right place? What's the intensity? What's the dose of care? The dose of care is actually something you find in the ASAM criteria. Now, there are 3 things that this does on the left, and they're actually in opposite order, but they're in the patient's order going up. So first, it's a multidimensional patient assessment tool, generally required in many, if not most states now, for insurance companies to either cover or not cover. So the ASAM criteria, you'll hear about this because WIT versus UBH really set this out as precedent. So it's very much like what you know by going through DSM-5, right? It's a multimodal way of looking at biopsychosocial issues to help determine what are the patient's needs at that point in time. And then the second thing it's done is it's used to match patients to the appropriate level of care based on that where they are at that moment But the underlying thing there is it provides universal standards that establish a full continuum of care. And that's what's missing right now. So, I mean, you know, there's no inpatient and outpatient. Inpatient is when the person sleeps there. Outpatient is when they don't. But there's a difference between general outpatient, which would be ASAM 1, and then intensive outpatient, partial hospitalization, between different kinds of places where you sleep, right? There's a difference between a skilled nursing facility and a hospital. And so there's a difference in the inpatient levels of care as well that are delineated through that. Because we don't have national standards and these states idiosyncratically license, then even when you make a diagnosis and you're saying, okay, this is the level of care the person needs, there is no way to know what a given treatment program actually delivers. So a lot of the data that we look at here for addiction, it's not even apples to oranges, it's apples to anchovies. States are so radically different and lack so much oversight. There's literally no transparency into what care can be delivered by a program. So a primary problem is that most addiction treatment programs don't provide baseline care. No one's demanding it. There's really no NAMI in place. NAMI, as you will remember or have been taught, was really built by psychiatrists, the pharmaceutical industry, and relatives of people with what then would have been chronic mental illness. And that's the basis of where NAMI came from. There's no such coalition here for addictive disease. Only around 40% of any addiction treatment program in the United States, all of them, use any of the 3 FDA-approved medications for OUD. And even if they use them, they often use them only for, quote, detox, which is inappropriate. And can you imagine that for any other disease? I assume that there's still a board question about the Chestnut Lodge case, Osheroff versus Chestnut Lodge, where Dr. Osheroff went into the psychiatric hospital. He was a nephrologist, and he had major depression or bipolar disorder. They did what they did back then. They regressed him and regressed him and regressed him. He got worse and worse. He wanted to get out. He couldn't get out. He was there for months. He finally managed to get out. He went to another facility. They put him on medications, and in 3 weeks he was substantially better, and he sued. And this is where the duty to treat comes from for us, our duty to treat as psychiatrists, right? It's part of our ethical responsibility. So you probably can't imagine at this point that there are any psychiatric hospitals in this country that an insurance company is going to pay for that doesn't believe in medication and wouldn't offer antipsychotics to a patient who is psychotic. This is the status we're in with addictive disease now. So you'll hear a lot about abstinence-based programs. So abstinence-based, I'm going to define it as restraining intentionally from pathological pursuit of reward or relief that involves the use of substances or other behaviors. That's the ASAM definition. And what people don't often understand is that using medication as prescribed, medications for opioid use disorder or alcohol use disorder or tobacco use, just nicotine addiction, is actually considered consistent with abstinence per ASAM, Alcoholics Anonymous, Hazelwood Betty Ford, Smart Recovery, the United States Health and Human Services. Only Narcotics Anonymous doesn't agree with this and thinks that taking medications for addiction means you're not clean and sober. Earlier in my career, it was not uncommon for a patient to say they couldn't say at an AA meeting that they were on Prozac because they would be told that they were not clean and sober. They were using a drug as a crutch. Biopsychosocial, we've got FDA-approved medications for these 3 substances. I assume that you're all going to be competent in using all of the substances. I was talking a minute about buprenorphine or methadone because we've got more data on methadone with OUD than we have on almost any treatment for almost any disorder, not in psychiatry, just across all of medicine. And the buprenorphine data is also incredibly strong. And so while people are taking the agonists, it cuts their premature death rates in half while they're taking it. And as soon as they stop taking it, their risk immediately goes up. And it doesn't matter if you increase their counseling or increase their care management, or if you do anything while you're trying to taper them off of their buprenorphine or methadone, their risk immediately goes up. Okay. The one thing that's cut overdose rates that I can tell you is that in Rhode Island, this is a Stacy Green study, it's a great study. When people were being released from incarceration, they had OUD, they got their option of taking, starting before they left, methadone, bupe, or naltrexone. You can see about 2/3 chose methadone, 40% chose bupe. Almost no one chose the Vivitrol extended release naltrexone. And as opposed to sort of the 6-month period in the year before, they dropped their death rate so much that it dropped the death rate for the entire state from overdose. That's how effective agonist treatment is. This is how you should know how to use the treatments. These are the 3 major documents that you should be familiar with here. And there is no reasonable medical debate about this. There is no reasonable medical debate about this. Using the medications in an ongoing way saves lives. Withholding or failing to have available these in the criminal justice system is denying appropriate medical care, National Academy of Medicine. Withholding them in any setting, say, oh, this halfway house won't take people if they're on buprenorphine, unethical. Go through the SAMHSA tip 63, says very similar things, right? The term medication-assisted treatment, insulin does not assist the treatment of diabetes. Buprenorphine does not assist the treatment of opioid use disorder. It is treatment. It is core treatment. Insulin is not the only treatment. It is not sufficient in and of itself treatment, okay? But it is treatment. So ASAM says if you're going to say MAT, it's medication for addiction treatment. SAMHSA tip 63 doesn't talk about MAT. It talks about medications for opioid use disorder or pharmacotherapy, which is the bottom, MAOUD. And the National Academy of Medicine report uses the term medication-based therapy. Now, you know your standards for medical care is informed consent, right? You have to discuss risks, benefits, and alternatives. If you've got a patient who you know has got addictive disease and you don't discuss risks, benefits, and alternatives of prescribing them FDA-approved medications for their diseases, you are not engaging in informed consent. And your patients have substance use disorders. If you're not checking a drug test, you have no idea what your patients are really taking. You are not omniscient. You don't know. You can't know. If you think you can tell, you are really kidding yourself. If you're not doing a drug test, you have no idea. And your patients have addictive disorders. And whether you ensure that they're getting appropriate diagnostic and treatment and care so that they can manage their disease and be there for their kids and be there for their elders and have good health outcomes, that's up to you. But as psychiatrists, we are responsible not only for the care that we provide, we are responsible for the care that we choose not to provide, acts of commission or omission in your malpractice coverage. So your example, I think my patient has addiction. I won't or can't treat it. So I'll tell them to find a counselor somewhere, refer them to a non-medical practice I've heard about, even though I don't know if they provide appropriate care, discharge them from my practice as soon as they're not perfectly adherent to the treatment plan. Really good ways to get yourself sued and lose a lawsuit. Now, I hear this occasionally from psychiatrists. I don't treat addiction. That's a subspecialty. Really? So never, when you're out there in your world, are you going to perform consultations in your hospital, even though you aren't subspecialty boarded in CL psychiatry? You're not going to see a person over 65 because you're not boarded in geriatric psychiatry. And look at all these other subspecialties to which we have access to be board certified, sub-certified as psychiatrists, sleep medicine, pain medicine, hospital. Do you never treat a person with a brain injury because you're not subspecialty certified? Certainly not. Okay. So this is me going through my initial piece on us as psychiatrists. And since I turned my phone off, that it wouldn't buzz, I have no idea what time it is. So, oh, good, I'm in good shape. Yay me. So now I'm going to talk about the implications for systems as a chronic brain disease. Now let me go back one more. Let me go back one more as psychiatrists. When I tell people that psychiatrists have 1 month of training in addiction for 4 years of medical school and 4 years of psychiatric training, they're shocked. Our physician colleagues are shocked. Our patients are shocked. The people in our communities are shocked. They think these are our disorders and that we treat these. And I've heard a lot of psychiatrists talk about how we need to make sure that in primary care or as people are dealing with pain, that we are attending to their affective disorders and their trauma and their anxiety disorders and etc. But if we're advocating for other specialties to be doing a better job and utilizing and attending to psychiatric issues, and we're not doing the same for addiction, then I have to wonder if we're not sort of being hypocrites out there. So I'm putting this out there for you. If anyone started this talk thinking, I don't treat addiction, it's almost like, well, if patients have behavioral problems, we'll send them to psych, sort of like things rolling downhill. But sometimes it seems like this is just one more addiction, sort of one more downhill from psych. And I'm sure that's not the case at U of L, but I've seen this in other areas, and it's just very disconcerting as a psychiatrist to see that happen. So now I'm going to pivot to this paper in the National Academy of Medicine's perspectives on very exciting title is Guide for Future Directions for the Addiction and OUD Treatment Ecosystem. It is based on the underlying constructs that I just talked about this is a chronic brain disease. This is a relapsing, remitting brain disease. We don't cure people. People don't graduate. Can you imagine someone say they've graduated from their from their diabetes treatment at our program? This is nonsensical. This is nonsensical. Now, not everyone who has a substance use disorder will develop the chronic brain disease of addiction. Okay. In fact, most people who've got a problem, a demonstrable and even a diagnosable problem with alcohol at some point in their lives will move through that with no treatment, no support group assistance. And we often see this in people in their late teens, early 20s, where they really are having some functional problems because of alcohol, but it's sort of, it's like time limited for them and they move through that. Okay? Not everyone develops the brain disease. When people do develop the brain disease, very much like every other condition, think diabetes, right? Sometimes women will develop diabetes during pregnancy, right? And then they deliver, their sugars normalize. Does that mean they don't have diabetes? No, of course not. They just are not showing that they have diabetes. They have that underlying diathesis. It's simply, now it's quiescent. It's in remission, but we know their risk for becoming symptomatic with that as they age is quite high. So for a relapsing remitting disease state, not everyone needs treatment at all points in time that's active. Not everyone will need maintenance treatment at all times. It depends on the individual and what the treatment is for them. Okay? But with the underlying construct that these are not acute conditions where you go and get fixed and are done, that makes implications for the entire treatment system. And this paper is based on the same underlying constructs that I just told you. So it's not just about those underlying constructs. We're going to be talking about the 4 C's that are delineated in this paper, but there's all of this, right? We're humans that, and our conditions, no matter what they are based on a wide variety of our needs and our histories and our medical backgrounds. Okay, but what the paper does is says, okay, we are wasting an enormous amount of money right now on, quote, treating the opioid epidemic, unquote, and we need to develop ways to put that funding where it actually should go. So we're looking here for 4 C's. Do we have capacity, competency, consistency, and compensation? Meaning, do we have the right sized system? Do we have capacity to treat the people who've got addictive disease? Competency is, do we have the right knowledge base for the people who are treating addiction? Consistency, can we count on the quality of care in addictive disease treatment? And compensation, are we paying for the right stuff? And of course, the answers to all are a resounding no. Addiction treatment is not adequately taught anywhere in our training programs. Much of the country's got no access to providers whatsoever. We tolerate a level of lack of quality of care for substance use disorders in this country that we would never accept for any other kind of disease state. And most, I'm going to say most, it's much, but I mean, really most of the OUD treatment in this country is harmful rather than helpful. And I'll give you this is a simple example. When people with OUD go into a detox / 28-day rehab and they leave prematurely, they do better than when they complete their detox and their 28-day rehab. The people who complete their 28-day rehab have a higher chance of dying when they leave that than had they never come in the first place. And that's because they've lost their physiological tolerance. And even if you tell them you can't take as much OxyContin, whatever, as you had before, they still have lost their tolerance, and they leave rehabs. If they're not on agonist medications, they die at a higher rate than if they'd never gone there. And this is very true as well of people who are leaving incarceration. They've lost their tolerance, they leave, and they overdose, and they die. And when Marv Sepula up at Hazelden noticed that the same things that they'd been doing forever in Hazelden that was so helpful for treating all kinds of addictive disease, they sent their people home after the normal program, and the patients died. He said, hey, we can't hold our ideology. We have to follow the science, and started using agonist treatment and was literally booed off of podium, off of at least one podium by the people in the quote treatment industry for this stance. Capacity. Do we have all the levels of care that we need to have? Do we have, and you'll go through the paper, these different kinds of capacities, not just prescribers, right? We need all of the workforce. And as you know, our workforce, our mental health workforce, is not trained in addictive disease. Our social workers, our psychologists. Do we have the capacity for telehealth, for naloxone rescue, for syringe exchange programs, and then those underlying things that we're calling social determinants of health, which I'm just going to call it underlying, Maslow's needs. Competency also talks about how are we training people? How are we evaluating them? How do we know what we're giving, that what they're getting is appropriate care, and how do we help train them? Okay. The kinds of core competence for medicine that have been out there for 20 years from the IOM study 20 years ago that have gotten baked into other specialties have not come in to this part of psychiatry, into addiction at all, at any kind of scale. So there are problems throughout why this is happening, but let's just call it. There is a very deep issue in how healthcare practitioners and the public understand addiction as an illness, as opposed to just bad choices, bad behavior, moral failures, right? It is very hard to fight your own brain. Go back to Nora Volkov's PET scans, right? Brains are changed. It is very hard to fight your own brain. Consistency of care. So you'll see a big push right now toward paying for care. And it's important to understand always that pay for performance has to be based on process metrics first. You can't just say, oh, we've saved money this year on diabetic care if you haven't done their retina exam and their foot exam and their A1C check this year, right? There are process metrics which must be done before you get into anything else. There are some process metrics in place for addiction. They just haven't been widely adopted, and they look a lot like the ones for depression and et cetera. And then compensation, we have a long way to go here because we've carved out addiction from mental health, carved out from physical health. Because we have such silos, we sort of squeeze a balloon by trying to decrease payment in one area and it increases the cost in another, but it's not that place's problem. The mechanisms for evidence-based care and the requirements for process metrics that are in place for medical treatments of all kinds are just not put in place for treatments of addiction. So parity cuts both ways, folks. It means not only should the payer pay for care that's for behavioral health at a level that it's commensurate with their physical health payments, but payments should not be made for that care if it would not meet the criteria to treat physical health, right? If you go to a cardiac rehab that doesn't allow you to take medicine, insurance is not going to pay for that, right? So if we stop paying for what we know doesn't work and focus on paying for what does work, then we can improve our outcomes and decrease our costs. There are some fundamental areas to be addressed here that are delineated in the paper. And I, of course, encourage you to go look at those. I would call out something that you might not know about is the kind of fraud in the addiction treatment area, which is enormous. I do a lot of work with the Department of Justice on criminal fraud cases for claims and against psychiatrists who are prescribing outside of legitimate medical purposes. That's a huge area. So I would refer you to, for your background, to the documents that I showed you earlier, and this is just some of the links to them. And we have to focus on education standards and oversight to get to where we need to go. And with that, I think I'm at the right area to stop sharing my screen. I think I've got a few extra minutes for questions, but I'm sure Dr. Stewart can fill in some questions. Or actually, Ali, you're fielding the questions? Sorry.
Yeah, but either of us can actually do it. So let's see, we've got one question here already.
You'd be better at fielding them with than I would, as far as the technology goes.
Well, first of all, Dr. Clark, thank you so much for that great presentation. So we've got a question from Arthur, who's one of our PGY3 residents. Says, thank you for your time, Dr. Clark. This is more of a personal choice question. I am very interested in addictions, including doing either a fellowship in addiction psychiatry or addiction medicine. As someone certified in both, what are your personal recommendations between choosing between the two / the strengths and weaknesses?
Oh, what a great question.
Don't answer that. Don't answer that question.
I think Dr. Stewart was just joking.
You should do the addiction psychiatry program at the University of Louisville. How was that?
Great answer. That was the answer.
Okay, so the answer for fellowships, I think, is always, what is it you want to do? Let me throw this out to the residents. Throw it out to faculty too. Offer, I will spend an hour having a cup of coffee with you to discuss your career issues if you ever want to take me up on that offer. So let's start with, why is it that you want to do a fellowship? What do you want to do with it? Do you want to become an academician? Do you want to teach or run a training program? If so, that's a really great reason to do a fellowship. You should look at what kinds of departments or where you might want to utilize that. So as a psychiatrist, you might want to do this in psychiatry because that keeps your options most open for academics later, because you could either teach in an addiction medicine program or an addiction psychiatry program. Are you looking to, what are you looking to do with it? Are you looking just for additional knowledge and education? Are you looking for where do you want to network through? Some of it really depends on where you want to go and what you want to do with it. As psychiatrists, we have options of both. As I've got to say this, Chris, sorry. You also have the option still, if you're doing significant after you're done with your residency, to grandfather into addiction medicine board without doing a fellowship. After you've been out there working for a little while. You know, I'm old enough that grandfathering is how we did it. So there really is, though, something to be said for getting that well-rounded education of doing a fellowship. There is a lot to be said for it, because it took me a lot of years to get the well-rounded, I hope, approach that and knowledge and understanding that I now have. So I think it depends on where you want to go with your career, where you want to go to follow your spouse doing their fellowship and where it's available. And then the faculty you really want to work with. So that's my answer.
By the way, great presentation. I'm going to jump in real fast. That's okay. I just really appreciate your take on things and how you present things, as always. Really enjoyed it, and I appreciate again you coming here and doing this talk for us. You being the past president of ASAM, you do have a substantial amount of experience and knowledge with the development of the Board of Addiction Medicine and how that came about. So I know, I was just kidding. Feel free to talk about that. I'm board certified in addiction medicine and highly treasure that certification and affiliation with ASAM. So I was just kidding before about that, obviously. But you have been somebody who has been, a big advocate for the addiction medicine certification, and I think it has been really helpful in the field to do that. And I know there are fellowship programs in addiction medicine too that are starting everywhere. And there's been a huge amount of funding to increase the number of programs. And we've even looked at that, of having both. So I don't know if you want to say anything about that, feel free.
So, okay. So I would say, since it was sort of the question, there is an addiction psychiatry fellowship that leads you to take the subspecialty board under the ABPN for psychiatry. And there is an addiction medicine fellowship that lets you sit for the board under APPM, preventive medicine. And addiction medicine is a field, much like pain medicine or palliative care medicine, or a number of different kinds of medicine where people from different specialties can go through the fellowship and become boarded. So it's a multidisciplinary approach, just like pain medicine. That one's for, I think that's for the training director here. Options doing electives as fourth year residents.
Ali, I think that can be addressed by Dr. Caudell in terms of what's available. As you guys all know, we all do our SUDS rotations, our PGY 2-year, and then there are other options that are available. Now, I actually had a question about the systems-based approach to addiction medicine as well. Do you, it's interesting that you talked about the fact that the treatment for addiction has kind of been siloed and we psychiatrists have not really taken responsibility for the treatment of these patients historically. Do you think that the creation of AA in the 1920s kind of took that away from us to a certain degree, like the community already took responsibility of that before the science within medicine in general was developed enough to kind of keep up with the demands that society was having at the time? Did that kind of already create the atmosphere where it'll be very difficult for us to reclaim that now that the community at large has kind of run with it over the last 100 years?
Sure. So yeah. So I don't know that we ever took it in the first place at the beginning of the 1900s. And so AA came out of a charismatic Christian movement in the U.S., sort of based straight out of that approach, and because really it was not sort of medicalized, the same way that psychiatric conditions were sort of carved off and shoved to the side. And prior to Thorazine, psychiatric hospitals were just, if you haven't seen Titicut Follies, you should definitely find Titicut Follies and watch that as psychiatric residents. just sort of shoved off to the side, and because we didn't really have the kinds of treatments to deal with psychosis, and we didn't have good treatments to deal with alcohol use disorder, which is sort of primary issue then. So I think where we are at this point, I liken the use of buprenorphine to Prozac, because before Prozac there were tricyclics and MAOIs, and the change that happened when Prozac came to the US in like 88, 89, was really sort of structural within the field. Not quite as much of a change as when there were antipsychotics in the 50s, but I think buprenorphine really is showing a very similar kind of movement here. There is this long-standing, very ingrained industry in this country, the legacy historical industry, that makes refrigerators, that makes ice boxes, and what we need now are refrigerators. And it's very hard to move funding when you've got an entrenched voting bloc making ice into making refrigerators, and that's what we're having to do right now. Congress appropriated, so there's a process, in Congress where they can say, okay, yes, we will pay for this, and then they have to actually appropriate money to pay for it. Congress appropriated billions of dollars in the past 3-4 years to the opioid epidemic. Hundreds of millions of dollars of it remains unspent. We don't have the infrastructure through which to deploy those funds. We don't, because they were supposed to go to evidence-based treatments, right? We don't have anything near that infrastructure. And therefore, funds went out for things like lots of naloxone rescue. Well, that's great, but rescue is not going to turn the tide, right? They went out for, a variety of things, drug disposal, medication disposal, great, but not going to turn the tide. We don't have the treatment infrastructure, and that is the primary piece that we've got to be building that goes along with the payments. We need to stop these payments for things that we know are harmful. It's ridiculous. And we as psychiatrists have to step up. These are our disorders. Who do we think is going to have them? It's not like there are not enough of us. There are 10 times as many of us as there are addiction doctors. 10 times.
I might add you to say a little more about these are our disorders, in that these patients with addictions tend to have other psychiatric problems, in my experience, and so they tend to be our patients for other reasons too.
They are our patients. You look at that Venn diagram of the overlap of those co-occurring disorders, which you will do immediately before taking your board exam. I haven't done mine for 3 years since my last re-up, so I don't know offhand, but it's a very big overlap in your Venn diagram. And the truth is that too often psychiatrists are just sticking their heads in the mud going, no, my patients don't have addiction. Okay, well, pretending they don't and asking them and having them say no really doesn't get rid of your responsibility. It's not going to be helpful to keep changing their medications for their affective disorders and their anxiety disorders when they're drinking a fifth every night and you don't know. So, the same way that you would normally be, when people come in and they're not getting better after their first round of an SSRI with their depression, do you not send them for a TSH to see if are you giving treatment for the wrong disorder? Well, if they're not, do you not get a drug test on them? And if they're not willing to do it, what does that tell you about them and your initial differential? You missed it. You missed it because you didn't want to know, and you didn't ask because you didn't want to know. And often we don't want to know because we don't know what to do. See, and that's not a good answer. These are our disorders. We should know how to do motivational interviewing. We should know how to do motivational enhancement. We've got 3 kinds of substances for which there are multiple FDA-approved medications that we can access for our patients, and need to do so if we are going to give informed consent, appropriate legal and ethical care.
Thank you. Dr. Shanebacher, who's one of our attendings here, has a question on the Q&A. Can you comment on the limitations on prescription by licensure, specifically with regards to a generalist discharging an opiate addict from the hospital or consult service? Is there a movement to allow methadone and buprenorphine prescriptions to not be as limited?
Well, buprenorphine prescriptions aren't really limited. There's no particular limitation on that. It's a Schedule III drug. So if a person is being discharged, if they've got OUD and they're in the hospital, hopefully they're on buprenorphine, would be your best option, assuming they're in the hospital for an OUD related thing, right? Infected heart valve, cellulitis, whatever that is, wherever they're there, motor vehicle accident because of their drug use. So hopefully they're on an agonist when they leave. Now, you cannot prescribe methadone to treat addictive disease in the US. It's a violation of the Harrison Narcotic Act that was like 104 years old or something. So you cannot prescribe it for that. You can prescribe all you want for pain, but not for addiction. It has to be ordered and dispensed through a licensed OTP, opioid treatment program, of which there are several here in Louisville. So prescribing, you should not be putting somebody out with a prescription for methadone to treat OUD. Don't do that. But you can have them go follow up at the OTP, absolutely, and you should have some process in place. It's surely at the university hospital to get people inducted and then stabilized on methadone there. But buprenorphine doesn't really have any such restrictions. I mean, you do your 8-hour course, which.
Yeah, I think that maybe, I wonder if the question is if you don't have a waiver, if the doc who's seeing the patient in the hospital does not have a waiver to prescribe buprenorphine.
Why would a doctor at a university hospital not have done a little 8-hour training to prescribe buprenorphine?
Now, there's quite a few people who don't have their waiver. You're aware of that?
Yes, but I'm asking why at a university hospital with a CDC announced epidemic of overdoses in a state that's got higher than average numbers of opioid overdoses, in a university hospital where people are coming in with the medical sequela of their OUDs, would any attending not have an X waiver? Other than they choose not to engage in appropriate evidence-based care. They don't want to take responsibility for providing appropriate care. Well, how could that be at a university hospital, I ask you?
So
Am I offending anybody on the call?
Get your waiver, right? Basically, that's the answer to that. I would say there was a real attempt, and there has been, when Dr. McCann's cats came, this is a question we had. What about getting rid of the waiver and letting people prescribe it, rather than go through that? Isn't it a barrier to people getting to having this be more integrated into everyday medicine? I mean, I think that's one of the issues. It can be a barrier for a lot of people who are, admittedly really overwhelmed with their own responsibilities in their own areas. But like you said, recognize that they're being asked to deal with this problem, and they're confronted with it, and they want to do it, but for whatever reason, they haven't found it time to get the waiver. We had a big initiative where we trained a lot of people in the waiver and got more waiver docs. But even in the university, the majority of our docs in the hospital don't carry a waiver as far as throughout the entire hospital. And we have record numbers in internal medicine. We increased the numbers in our department, but still, we in the ER, we don't have, a lot of docs don't have a waiver in the ER. If you and in the ER, our patients come into the ER and they're not necessarily able to get that. We've had more residents get waivers in some ways than faculty.
Yeah, that's right.
So
that's right. Because when you deal with issues of discrimination, we find the younger people tend to have lower levels of this.
But what about the part where, if you don't have a waiver, can you prescribe it to somebody leaving the hospital?
No.
Okay.
No. And so there's two things about the waiver. And yes, the waiver is discrimination, unquestionably. So there's two things that are a part of that. The first is that there's a federal piece of this. And the second is that there's a state piece of this. And so residents, you have to know whatever state you're going to, they are going to have different regulations than where you train. And you need to know what you're doing in the state in which you are prescribing, because where that patient sits, even if you're doing telemedicine, where the patient sits is where you'll get sued. That's what you have to follow, is where they sit. So in Kentucky, even getting rid of the X waiver nationally would not get rid of it in Kentucky, because Kentucky has put their own restrictions on. Kentucky is the only state that I know of that just like last month outlawed telemedicine-based opioid treatment. Absolutely absurd. You know, we're dealing with a very entrenched legacy industry and a lot of stigma. But just getting rid of the feds, you have to go state by state. And then you have to go to the issues of the payers, because the payers are going to have on their policies that they have to be data waived in order to pay for this as well. So what happens when we start with some kind of regulation is that peeling off the regulation takes a really long time. And there's very rarely anything that looks like a simple fix for that, right? Any simple fix to a complex problem just leads to unintended consequences. So, you know, how much CME do we do? A ton. How hard is it to put the CME thing on while you're, you know, doing your notes and you're listening to it in the background? No, people are not getting their waivers because they don't want to feel responsible for using their waivers. This is simply a stigma and discrimination thing. And, you know, if you have to in the U, pay doctors $500 when they get their waiver.
I think we've got a resident here. Ethan, do you have the question, I think, as well?
Yeah. Hey, Dr. Clark. I'm Ethan Short. I'm one of the fourth-year residents, actually going to be working in addiction when I get finished. First off, you got me all fired up over here because you're obviously super passionate about this. And I love the way that you continue to reference other chronic medical conditions throughout your presentation. I hope you don't mind. I'm going to take that for my own presentations moving forward. But other than destigmatization, making MAT and collaborative care services more available, and some of the compensation issues, what do you see as kind of the solution on the illegal drug front, on, you know, drugs being smuggled into this country? Do you think there is a solution, or is it a war that is lost no matter what we do?
Yeah, no, no, that's not a solution. You can't stop that. That's not stopping. All that happens is you get a huge game of whack-a-mole, right? So, this is a matter of demand reduction. We've got to drive with demand reduction at the same time we move with supply reduction. One doesn't do it. So, you know, at one point they reformulated OxyContin. They reformulated it so that it was sort of slow release. And now people didn't like to shoot it as much. It did something with it. So they moved it over. It was a problem when they snorted it. So people started instead, amazingly being allergic to OxyContin, they now wanted Opena, oxymorphone, right? Simple supply and demand, right? Supply reduction without demand reduction leads to increase in prices and the development of substitutes. And that's how we got more heroin, and now fentanyl is substituting for the prescription opioids. So we've got to do demand reduction. The way we do demand reduction is not by sending people into a school and talking about, please don't use drugs, it's bad for you, because actually what happens when you do that? What does the data show? It either does nothing or it increases the rates that kids use. That's correct. Yes. But we do it because why? It makes adults feel good, right? We're doing something for the kids, right? It's harmful. We keep doing what's harmful. So what does work? What works is resiliency skill training, teaching people, and not just kids, parents, teachers, all the people in the community, how to cope with their stress and anxiety and et cetera in ways that are not drug use or domestic violence. Actually, I think the data look pretty similar, that resiliency skill training actually helps decrease with domestic violence as well. So we have to do something so people are less likely to be taking and continuing to take the drugs in a demand reduction sense. And the supply reduction sense is really interesting. You're talking about smuggling illegal drugs, because what is the movement right now? Huge amount of money into legalizing drugs. Billions and billions of, so we've got Soros funding the Drug Policy Alliance. The Drug Policy Alliance has sort of infiltrated its way in through. And now, sort of, if you talk about social determinants of health, suddenly you're talking about people who use drugs instead of people with a substance use disorder. And this whole conflating this construct that, you know, meeting people where they're at means allowing anybody to use whatever drugs they want. And what did we go back to my earliest slide about prevention, right? Using drugs is a risk. Using drugs early is a risk. Using a number, the amount of drugs is a risk for developing this brain disease. But we are pushing right now as a culture toward destigmatizing drug use instead of destigmatizing the disease of addiction. And that is going to cause us a lot of problems.
So it brings back to Aldous Huxley and Soma a little bit there. But Laura's got another question here. She says, were there any differences in death rates with Suboxone versus methadone treatment for those receiving MAT?
Oh, good question. Not statistically significant. Go look at it's an awesome article. If I said that, by the way, as you guys go and look at the things I told you, if I told you something wrong, come back to me and say, yo, you screwed that one up, Clark, okay? But no, there's just, nobody chose they don't like the Vivitrol, the naltrexone. And so literally less than 1% chose it. But we do actually, so what we do see with the naltrexone, it's got a black box warning because people will try to override the blockade and they'll overdose and die. They lose because they're losing against their tolerance.
All right. I know we've got some medical students here too, and we got some junior residents here. Does anyone have any, do you guys have any comments or questions for Dr. Clark? Not every day that we get to speak to a.
I got a question, by the way. I do. I'm not a medical student, but but if nobody else has a question, I've got one. I would want to hear. So we're in the middle of a pandemic, a COVID pandemic, and it has had an influence on treatment, particularly medications for opioid use disorder. You mentioned drug testing and how important that was to identify people with. Are you also maybe aware then about the controversy about drug testing and MOUD? And I just wanted to hear your thoughts about that, and particularly as we are dealing with the current epidemic and people having access to the treatment, to buprenorphine especially.
Okay, so a couple of things about drug testing, and I would refer you to a paper of that ASAM has on the use of drug testing in clinical addiction medicine, which will lay out a number of issues for it. Just so you know, different groups do different things, right? So you know about AAAP, which is the addiction psychiatry group. They do a lot of stuff with research. They do a lot of grant stuff and a lot of research, and they do the PCSS, and ASAM does a lot of stuff with practice guidelines and like national policy stuff, payment policies and et cetera. So kind of join both. You should join both. Anyway, how was that, Chris? Did I do okay with that?
That's great. No, but I want, yeah. But
right,
I mean,
so
I wanted to hear your thoughts about this.
Couple of things on drug testing. So first, what I'm advocating for is drug testing for the general psychiatric population, not somebody who comes in and says, I've got drug problems. But the general psychiatric population, the primary care folks are supposed to be screening every year as well for illicit drug use. So why shouldn't we? And then the second issue around drug testing is around be careful. When you order a test, you are responsible to utilize the results of those tests, right? Otherwise, that's not medically necessary. I do a lot of cases. I'm actually an expert at a trial later this month in Florida, where a quote treatment center end quote was billing a couple $1,000s per drug test. And they do it multiple times a week, and they never act on the results and et cetera. So if you're ordering a drug test, what are you ordering? Why are you ordering it? What are they billing for it? You sign it, you own it. So you want to make sure that you're using that, and you really need that information. Okay, super important. So next up is that drug testing is a very valuable part of addiction treatment. And it should be used as a part of monitoring, diagnosing, and managing the patient. It should not be used in a punitive way at all. It should be used to make sure that you and the patient are providing, that you're giving appropriate objective feedback on how they're doing with their sign of their substance use disorder, which is a use of the substance. It should always be discussed with the patient. And it should be like, well, so you popped back up. I've got you. Okay, so say they're on bup, right? Well, you're positive for oxy last week. What's going on with that? No, here, it says you used it. So yeah, I'm not going to discharge you. Just what happened? Let's figure out how we can deal with this better together. Okay, well, my brother came over, and I always use when my brother came over, and he came over and he just popped some pills down, and then let's just, okay, good. Well, thanks for telling me that. Okay, so what could you do in the future so that this doesn't happen? Okay, that's how you use a drug test, right? And the other way you use a drug test is, wow, look at this. Good. Look how great you're doing. You came back negative. Now, is there anything that I missed on this drug test you want to kind of talk about now? Otherwise, great. Do you want a copy of this to go show your, spouse? Right? And always make sure you've got validity tests on there. I can't tell you the amount of non-human pee that I see, right? That I see through everybody's medical records, right? Creatinine, pH, okay, specific gravity. But the access issue is one where, now drug tests can be done in a multitude of different ways. We can do them quite well on telemedicine. I work with a company that does telemedicine stuff, and they will literally send the patient a drug test in the mail. There it is, urine cup. Okay, off you go, I'll wait. Okay, show me the temperature gauge. Show me, okay, good. Let me see you put the strip on it. Sign, good, off you go. Okay, you can do the swabs, which do not have as good sensitivity and specificity as urine does. And it takes the spit tests take a long time actually to get enough spit into the spit test. But at any rate, and you can also have people go into any of their primary care provider or wherever to get testing done. So urine testing is an important part of treating addictive disease, but it is not the solo requirement. It can be a barrier to access that you should try to work with, or the system you work with should be working with patients to try to overcome any of those barriers to access. So we always balance out what's the cost and benefit of any test, right? Always. Is it, do I really need this person to have an MRI? What if they didn't have insurance? Do I really need them to have the MRI? Do I really need them to have this test? And that should go into your cost benefit analysis for the patient, how they're doing at that point in time, what you feel like also your risk is, what is your life, the last 3 times you were positive for benzos, I'm kind of scared with you being on methadone because you're not prescribed this, so I need another test. It depends on where you and the patient are at that point.
Kind of, there's kind of an interesting question here from also from Laura, one of our PGY3s, is how are they doing things in Europe compared to how we're doing things here? How many countries in Europe are managing OUDs compared to the US? Which I think it's kind of interesting to know about, because I know we know from a lot of different diseases as well, especially some surgical diseases and things like that Europe does things a lot differently than how we do things here.
Well, Europe isn't a country, so different countries deal with things in really different ways.
EU.
What?
The EU.
Still not a country. That's an economic entity. That's how they are put together. They're not put together with the same laws and regulations around everything else, right? So you'll hear a whole lot about France putting buprenorphine basically in the water. Don't drink that Kool-Aid. Go look at those data and why that's the case with so much buprenorphine in France and what that means. The truth is that nobody's got the kind of problem with opioids that we have, right? The US is 5% of the world's population and 85% of the world's hydrocodone prescriptions. We prescribe pain meds. That's what we do. We prescribe benzos. We prescribe stimulants. We prescribe all kinds of stuff that would never be. You get a hip replaced in Norway and you're not getting opioids. I mean, the stuff that we think, oh no, right? They just don't use them, right? So we do. So we've got this problem. And we also have this problem because of the hyperesthesia, hyperalgesia that happens with the opioids that we still, too many doctors don't understand. And they don't understand the difference between dependence and addiction. So when people are in withdrawal, physiological withdrawal, patients think, I can't make it without. I tried to make it without. I need a detox and a rehab. I'm addicted. No, you're just physically dependent. And I will tell you, most doctors won't make that appropriate diagnosis. Not trained in it, don't know how to do it. Oh, you can't stop your opioids? Okay, off to a rehab. Totally wrong place for physical dependence only, without person having lost control of their lives because of their drug use, right? And having lost control of that drug use. So what happens with opioids, you know about the hyperalgesia, hyperesthesia? So Chris, you know, that doesn't help me. The resident didn't say yes. So, okay, so you use your opioid and your pain goes down. But then as it wears off, actually, what happens is over time, you use again, it goes down, it comes back. Your baseline pain goes up. That's your hyperalgesia, hyperesthesia, right? So what people find when they stop taking their opioids is they have less pain once they get over that withdrawal and nightmare. Very much I tell people it's like, you know, people who say that they smoke to calm down. Okay, well, if you're not physically dependent on nicotine and I give you nicotine, what's going to happen? Your heart races. You're going to start trembling, right? You can't sleep. You get agitated, right? Nicotine does not calm you down. Nicotine calms down nicotine withdrawal. That's what you're calming down. But you would actually be less nervous and anxious if you stopped smoking than if you continue the cycle of intoxication withdrawal, right? So Europe does things very differently, largely because they have a really different problem than we have. And it's country by country. So some places, pharmacies will dispense methadone. People get their daily dispensing there. There's a really wide range of different approaches.
I think we have time for about one more question. Anyone who's got.
And I can tell if nobody has a question, Dr. Stewart's going to have a question.
I could ask you questions all day long, right? I could.
I can blither all day long.
I will
Yeah.
call Dr. Clark up and ask her questions too, all the time. Yeah, no, I really appreciate you coming. I think that you did a great job, and it's also this part, getting to hear you talk about different subjects that sort of sheds light on your breadth of experience. That is really good to hear, and I'm glad that, you know, somebody's got a question. Looks like. Oh, no. Anyway, I always get a lot out of listening to you talk, and I appreciate you coming, and you did a great job.
Well, thank you. Appreciate the opportunity. Hope to see everyone in the near future then.
All right. Thank you, Dr. Clark. Thank you guys for attending.
All right.